Jess, are you there?
Yeah, there you are, Dr. Godwin. I couldn't decide if I was on or off and kept flipping back and forth. How are you?
I'm fine. I am unable to share here. It says that the host has not allowed sharing. So,
Yeah, we like to keep the seatbelt on you, Dr. Godwin.
Okay.
Hang in there. Do you mind if we take up just 5 or 7 minutes for announcements before we hand the microphone over to you? Cool. And meanwhile, Marcus will give you sharing permissions.
I'm going to need to have Ahmed do that. He owns that series.
Okay, Ahmed will take care of it. So Dr. Godwin, we'll just wait another minute or so to let more people Zoom in. And then we'll take care of announcements real quick. I'm seeing 1 or 2 new names. So for our new UW residents, our Virginia Mason residents join us for categorical lectures on Thursday afternoon. So that's great. So the 2 sister programs get to meet up, and then historically we've also had our Madigan residents come for Thursday afternoon lectures, but at some point they just kind of dropped off. So they might rejoin. In any case, welcome everybody. We've got 26 participants. I think we might reach a few more. Oh, we went down one. We lost one. Okay, well, out of respect for everybody's time, particularly Dr. Godwin's, I'll go ahead and get started. So good afternoon, happy Thursday, first categorical lecture of July. You're going to learn all things chess this month. So we kick off every Thursday with some announcements. And so first thing I can let you know is that this month we are going to start doing our 3+1 system of lectures. So the first 3 Thursdays of every month will be virtual like we are now. And then the 4th Thursday, you all will meet over at the University of Washington Medical Center in Turner Auditorium at 3 o'clock for in-person lectures. That will be our hybrid system as we kind of navigate the continuation of the pandemic and sort of take everybody's needs into consideration. Zoom is very convenient for a number of reasons. So we are going to do that, and we look forward to hearing how it goes. But today is on Zoom. Feel free to participate in Dr. Godwin's audience response if he has any, or just harass him liberally. And Dr. Godwin, I presume you will harass our residents liberally too. So to carry on, we've got some announcements that you guys will get in your newsletter. I want to make sure everybody has on their calendar Thursday, July 14th, 6 p.m. We're going to have a welcoming party. So put that on your calendar, July 14th in the evening. That's next week. We'll go to the Optimism Brewery and have some beer and pizza and fun socializing. So we'll give you some directions in the newsletter. And then, as you guys know, people keep getting COVID, unfortunately. And so when you're around other people, wear your mask, as we've emphasized last week at your orientation. And then if you do fall sick, let us know, but we can't tell you what the guidelines are as far as coming to work or not. We do want you to stay home if you're sick. And we definitely want you to stay home if you have COVID, but it's employee health that dictates how long you stay home or what you need to do. So in the newsletter, I had given you a link originally for a few weeks, but got more specific and gave individual phone numbers depending on the hospital you're at. So please, in the morning, call employee health for your respective site and let them know that either you've been exposed or you have COVID. What do you do? So thank you for following their guidelines and then letting us know. So just loop us in through the ResiRad and you email me as well, CC me as well. Okay, I know I'm forgetting something. Oh, what I'm forgetting, I want to encourage you all to use your cameras, at least in the beginning. As you guys have heard me say before, it is not easy to lecture to a black wall, which is what Zoom looks like when nobody has their cameras on. So don't be shy. You can look like a mess. And thank you. Hello, Kenneth. Hello, Edley. So nice to see you guys. So please, turn on your cameras at least for a while and let Dr. Godwin get to know you. He might not have a camera, so I apologize for that. Not all of us have cameras, but it definitely makes a difference for teaching. So lovely to see you guys. Thank you. And that's it. Any questions or chats from the group right now while I'm on? Okay. All right. Lovely to see you.
Tess, don't go away,
Yes.
Tess.
Oh, don't go away. Okay. Yes. Yes, sir.
So
Do
I
you
need
still
to
not
get
have
here.
privileges?
Oh, look at that. I can share.
You can share.
Okay.
Great. That was
Yay.
Okay, it worked.
Excellent. Okay. Thanks so much, David. Happy teaching. I
Right.
appreciate it.
Thanks,
All right.
everyone.
Bye, you guys.
Okay, so our topic this afternoon is congenital or congenial lung disease in adults. So just because you have something that arrives when you're a child, if you survive, you're going to have this as an adult. And there are lots of conditions that are congenital that show up only later on when somebody gets imaging or somebody has symptoms related to this thing that might have been there for a long time unsuspected. So we'll be talking about a few vascular conditions and then a few airway conditions. And this is a truncated list. There are many more conditions that we could talk about if we had lots of time. Okay, so we will start with arteriovenous malformation. We'll talk about sequestration, which is a really fun condition because it has both vascular and airway manifestations to it. We'll talk about systemic arterial supply to the lung, pulmonary sling, and then we'll talk about some airway conditions, pig bronchus, bronchial atresia, lobar overinflation, CPAM, and we'll finish with left lung isomerism, which is probably something you will see as a incidental and unsuspected finding. So we'll start with AVM, arteriovenous malformation, and this is a shunt between the artery in the lung, and you see the big artery snaking down here, and the vein without going through a capillary network. So this is a kind of right to left shunt. The pulmonary artery blood is right blood, and that is unoxygenated blood. And the capillary is not there to enable this blood to pick up oxygen. So unoxygenated blood is being piped directly into a vein, which is returning here to the left atrium and going out to the body. So these people will be cyanotic to a varying degree. This has a male predominance. It usually presents in the 3rd and 4th decades. They can be multiple in the lung, particularly when associated with Weber-Osler-Rondeau or hereditary hemorrhagic telangiectasia, HHT for short. So the manifestations, the most common is hemoptysis. People cough up blood, but they can be short of breath because this is a shunt and their blood is somewhat deoxygenated. They can have a short circuit of of an infection in the artery getting into the vein and then out to the body. So you could get a brain abscess or a kidney abscess, or you could have a stroke if a clot goes to the brain. So that may be one presentation of AVM. Polycythemia because of the deoxygenation and clubbing. I'll show you an example of clubbing from one of our cases here. So it can be remarkably hard to see AVM on a plain radiograph. So there's actually an AVM hiding down here. On the angiogram, you can see the little nut-like connection here. So you see this little blob here. And here is with more filling, and then we're starting to fill the vein. So we have an early draining vein going back to the left atrium here. So this is an arteriovenous malformation, almost imperceptible on the radiograph, but nicely shown on the angiogram. Here it is on CT with a MIP view. So we have the artery going into the vein. And here we have it in a remarkable color here with the artery going into the vein and then tracking back to the left atrium. So arteriovenous malformation here. This one got embolized, and so they put some coils in it, as you'll see on the radiograph there. Here's another example of a person with multiple lesions. This one is easy to see, this big lobulated thing. They tend to be in the mid and lower lungs. This one's huge. Here it is on the angiogram, and you can see it flooding back blood here to the left atrium. But there are two smaller lesions in the left base, nicely shown on angiography. You can perceive this one, but it's really pretty hard often to see the vessel. So don't count on seeing the vessel before you consider the possibility. So most often these things are presented as lung nodules on a radiograph, and people don't appreciate right off that it's an arteriovenous malformation. They think they might be dealing with a cancer or something. But there's one lesion out here, and there's another lesion hiding behind the heart, nicely shown on angiograms. So the thing is that you may treat these lesions, and then a few years later, the person pops up with more lesions. So microscopic lesions can grow to visibility over time. So you can do an angiogram, at this point have no visible lesions, but 2 years from now, you may find some new lesions that have cropped up. Here's an example of clubbing with arteriovenous malformation, pretty dramatic clubbing. Here's an example of brain abscess from this very small AVM here in the right upper lung. You can see the little nodule up here filling. And here's the catheter again showing that little AVM. So a small lesion here in the upper lobe. It's more common to be in middle or lower lung, and that led to a brain abscess, not a good outcome. And here's one of the complications. Sometimes if you treat these lesions, this was a case, an old case that was treated with resection, quite a big lesion was resected down here. The person will develop really uncontrollable pulmonary hypertension as a consequence. So this person had systemic hypertensive values here of pulmonary hypertension with a very large main pulmonary artery blown out by this pulmonary hypertension. This can lead to cor pulmonale and death. So one of the consequences of treating this lesion may be to put the person into a very difficult situation with pulmonary hypertension. Let's go on and talk about sequestration. This is there's a lot of confusion with this, this lesion, and this lesion involves a piece of lung that never really had a good bronchial connection. So it's bronchial elements that didn't connect up with the more central bronchi, and so they're sitting out there in the lung doing what bronchi do, which is to secrete mucus. And so you'll get a cystic abnormality that's filled with mucus. It may eventually get some air in it if there is fistulization from the surrounding lung tissue, or maybe from infection that causes a tunnel to form with airway. So if you get air into it, that implies a fistula has formed, but it's a cystic abnormality composed of primitive bronchial tissue that didn't connect normally with the main bronchi. So it's sequestered from the airway. It's separated, isolated from the airway. So that's the main component. Then it also has, as a secondary finding, it has a systemic artery supply rather than a pulmonary artery supply to it. So a systemic artery is supplying this lesion in the lung, and it's an anomalous artery that comes usually off the thoracic aorta, but it may come off abdominal aorta or other artery. And that lesion that artery is very prone to atherosclerosis, even at an early age. So premature atherosclerosis will manifest as calcification of the systemic artery. So we have an airway abnormality combined with an arterial abnormality. And here's what it looks like on this path specimen. A cystic abnormality here, multiple cysts, and it's usually in the left lower lobe, most commonly medially left lower lobe, second most common medially right lower lobe. So here's an example from the VA from Julie Takasugi, who retired as a chest radiologist there a few years ago, of this person who had the history of lung abscess for 50 years. And this is a series of cysts in the left lower lobe. You see them clustered back here behind the heart and next to the spine. And they have fluid levels in them, mucus levels or pus levels, depending on whether there's been infection or not. And that implies fistulization, because normally this should be an isolated mucus-filled cyst. If it gets air in it, that means that a channel is formed to let the air in from the surrounding lung or from an airway. So here's this cystic abnormality in the left lower lobe. This was a bronchopulmonary sequestration. So it's usually in the medial lung, usually left, more often than right, about 2/3. Cystic, solid, sometimes aerated components. You'll often see hyperinflation around a cystic component, or sometimes hyperinflation by itself. And the hyperaeration represents air trapping. So air is getting into this sequestered lung. It's not coming in from a normal bronchial supply, because that doesn't exist, but it's getting in there by collateral drift, and then it can't get out easily because it doesn't have a bronchial connection to get out. So there's air trapping. The systemic artery usually comes from the aorta, and it may have atherosclerotic calcification. So here are a few older examples. You see this mass projected over the spine on lateral view. Here's that mass on frontal view, tucked in medially in the left lung base. Here it is on this CT scan. It's vaguely cystic, it's hard to make out, but there's somewhat black lung around it here. So this is the hyperaerated air trapping component of lung tissue around the cystic abnormality. With injection of the abdominal aorta, we see this anomalous artery coming up from the abdominal aorta, crossing the diaphragm and perfusing this lesion. And then we see the vein, the pulmonary vein, draining the lesion. So intralobar sequestration, it's in the lower lobe. It has a systemic artery, and it has pulmonary venous drainage, which we see here later in the angiogram. So systemic artery supply, pulmonary venous drainage, classic intralobar sequestration in location and CT findings, and vascular supply. So intralobar is the thing that we see most often. It's in the lobe, usually the left lower lobe. There is a different kind of sequestration, which is completely outside the lung. It's surrounded with its own pleura. It's as if it's another lung, and it's usually tucked in along the spine, medial to the lung itself. But because it's completely isolated from lung, it doesn't get air in it. It has its own pleural envelope that keeps anything from getting in. So it's not as susceptible to infection as something that's in the lung that could get seeded from airway infection dropping down and contaminating all that mucus that's accumulated. So extralobar sequestration does not get infected. It has its own pleural envelope. The intralobar sequestration that I've shown you so far, they're all intralobar, and so they all drain to pulmonary veins. Extralobar gets systemic artery and gets a systemic vein. So it has no connection with the pulmonary circulation at all. It usually appears to be a mass, maybe a cystic mass, and it could look like a neural tumor, for instance, in that location. Intralobar gets infected because it's in lung, which is susceptible to airways infection from outside. Maybe you could get COVID in your sequestration, but extralobar is isolated, and so it's not going to get infected. Okay, and here's an example of extralobar. It's not quite in adults, only this person's 4 years old, but these cases are rare, so I don't have any others to show you. But here's this medial lesion here. You can't really see it on lateral view. And on CT, we see this funny blob of tissue down here. It seems to be sort of bow-shaped. It's tucked in near the aorta, and it does have a systemic artery coming out of the aorta and going into this tissue. And then this is the venous drainage, the hemiazygos, the accessory hemiazygos is the venous drainage. So we see at this point a vein meeting this hemiazygos or accessory hemiazygos vein, and then the blood crosses behind the aorta and gets into the azygos vein. So systemic arterial supply off the aorta and systemic venous drainage to the hemiazygos and azygos system here. Extralobar sequestration. This person has a right lower lobe lesion, and on the radiograph, the only hint you see is a fluid level here. So there is mucus or pus down here, and then there's air on top forming a nice horizon here. And here's the horizon posteriorly projected over the spine. So you guys all know the spine sign. That is, if you track the spine downward, things should get blacker and blacker as you approach the diaphragm, and they should not turn white. Here it's turning white. That tells you there's some extra tissue, and that's got to be abnormal. So it's usually aspiration or pneumonia, but it could be, as in this case, sequestration or something else. So the spine sign is the clue that there's an abnormality back here. And then on CT, we see that it's a cystic abnormality with a fluid level. It's got some other components here. Maybe there's a little hyperaerated lung around it, common in sequestration. Here is the artery coming off the descending aorta and crossing into this lesion. Here it is spilling into the lesion. And here we see a little atherosclerotic calcification in that artery. So premature atherosclerosis in the feeding artery, very common with sequestration. Here's a case that has bilateral sequestrations, also has pectus carinatum, so some other deformities. Here we have this cystic mass in the left lower lobe with some surrounding hyperaerated tissue. And we have a big artery coming into it very nicely here. And we have a big artery on the other side too, going into this hyperaerated lung. I presume that lower down that we might have found a cystic component too, but we've got abnormalities here in both lower lungs with systemic arteries feeding them. So bilateral sequestration in this case. And here is another example. This is a Korean example from a colleague, Dr. O, who lent me this case. So big cysts in the left lower lobe, looks a lot like Julie Takasugi's case from the VA, but even bigger. And he did some nice reconstructions of the arterial supply. So here's the descending aorta and a big anomalous artery going into this lung tissue down here. So this is the big systemic artery feeding this small amount of lung tissue. Here it is in a different projection. And so what's striking about sequestration is you've got a small volume of lung tissue, but you've got a fat vessel going into it. The vessel sometimes the size of your little finger. So that's a lot of artery going to this small amount of lung. So that is one of the striking findings in sequestration. And it's because it's basically feeding a low resistance system. You've got systemic arterial pressures and you've got pulmonary venous drainage, which is very low and a very low resistance filter between them. And so you can put a lot of blood through these things like that. So a big artery, and it's clearly an anomalous artery. That is a factory installed artery. That's not an acquired neovascularity kind of artery. So the vessel is quite big for the volume of lung tissue that it's supplying. So here's a couple of examples of a cystic abnormality with a fat artery, a big fat artery going into it. And here is during surgery, here is the anomalous systemic artery coming from the aorta and going into a left lower lobe sequestration. So here's a ligature around this fat artery. This is clearly a congenital artery. This is not an acquired arterialization, as you might see with inflammation. So there has been an argument, and for a while the AFIP and the resident teaching that was coming from the AFIP was implying that what we're calling intralobar sequestration is really an acquired lesion. It's not a congenital lesion. It's acquired because somebody got infected. they got neovascularity, and they had cysts in their lung, which might make you think of sequestration, but the cysts were really coming from infection or from bronchiectasis, maybe it was cystic bronchiectasis. So, so this sequence became the sort of dominant paradigm for the AFIP teaching of our radiology residents. And this is really a criminal act that went on for about 10 years and finally was corrected. So is intralobar sequestration really acquired? The answer is you can get a cystic lung abnormality from infection, and you can get neovascularity, but that doesn't really look like what we've been showing in sequestration. The big anomalous artery is a true congenitally abnormal artery, factory installed. It is not an acquired neovascularity, which has a completely different look. So there is such a thing as inflammation causing sequestration-like findings, and that is termed pseudosequestration. This is not made up. This is a term in the literature. So there is an entity called pseudosequestration, and it's separate from sequestration. So just because you can get infection with some similarities doesn't mean that there's not also sequestration. There is also sequestration. Okay, so it is definitely a congenital thing, but beware. There you could be dealing with infection, so make sure that the imaging is consistent with sequestration and is not really a manifestation of pseudosequestration. So another argument for true sequestration is that this can be identified in utero by ultrasound and other imaging, or in infancy before there has been a chance for infection. So you can see these lesions in people who have no hint of infection that could have caused pseudosequestration. So let me show you a couple of examples of pseudosequestration and neovascularity as opposed to anomalous arterial supply that we've seen in real sequestration. So here's somebody with infection and some cysts in the right lower lobe. And here is neovascularity from this systemic arterial injection. So this is a bronchial artery injected here, and you can see this tangle of this little web of abnormal vessels, these beaded and knotted vessels here. This is neovascularity. You don't see the big pipe that we've seen in our cases of true sequestration. And here's an example of cystic infection, chronic infection here in the right lung base in an older patient. And there are all these little points lighting up here of small vessels lighting up in this. And this is the neovascularity, again, of chronic inflammation. This is probably the result of aspiration in this location back here. I don't know what the cause of the infection and the cyst was in the case on the top. So this is pseudosequestration, chronic infection. This is neovascularity. It's not the same as the congenitally abnormal artery that I've shown you in the sequestration cases. Okay, now here's where it really matters. This woman, 42 years old, was sent in for surgery here because she had this big cavity in her left lower lobe. And she'd had this, and she'd had recurrent infections since her college days. So she's now about 18 years after college, and she has this abnormality. She has continuing symptoms. Here's what it looks like on CT. You can see that there is a cavity. There's some surrounding crud and scar, and there are these giant vessels. Look at all of these vessels back here. So we've got lots of big arteries. We've got a ton of them, and these are intercostal arteries that have really hypertrophied. So here's what it looks like in a coronal view. Look at all this tangle of intercostal arteries feeding this cyst and leading to hemoptysis. So what is this? Is this an arteriovenous malformation? No. Is it sequestration? We don't have a single artery. Sometimes you get two in a sequestration, but you never get a ton like this. It turns out that this woman had a history of aspiration when she was in college. Maybe there was some beer involved. I mean, that's a possibility. And ever since then, she aspirated, she's had these problems. So this is really pseudo sequestration here. This is chronic inflammation that has led to this periodization of her intercostal arteries, which are now gone into the lung and supplied this. The surgeon we reviewed this case and we said that this is pseudo sequestration. This is not sequestration. The surgeon, that message got attenuated, and what the surgeon was expecting was sequestration, which meant that he could go in and find a single artery and control it and not have a bleeding problem. Instead, he found that he had a row of intercostal arteries feeding this lesion. The patient required transfusion of 32 units of blood because of the massive bleeding associated with all of this neovascularity. So this is very robust neovascularity here, with these intercostal arteries becoming very hypertrophied and feeding into this low resistance system. So this was pseudo sequestration. Had he known that, his approach would have been different. He would have probably tried to control these arteries before he even went in, perhaps by some embolization in advance. Okay, so this was pseudo sequestration, and the surgeon was unequipped for this. It was many, many hours of very difficult surgery and huge blood loss. So let's just think about lung lesions that have systemic arterial supply. We've already talked about sequestration and pseudo sequestration. There's a condition called scimitar syndrome, which is a kind of left to right shunt with an anomalous vein that looks like a scimitar. We won't be talking about that. Pulmonary oligemia, if the lung tissue is not getting enough oxygen, it will stimulate systemic arteries to come in and supply oxygen. So you can see that with congenital heart disease, or with pulmonary artery interruption or hypoplasia, where you just don't have a good pulmonary arterial supply. And then you can have a systemic artery to normal lung tissue, not sequestered lung tissue, but an anomalous artery that comes off the aorta, usually the abdominal aorta, and goes into lung, usually the right lung base. So let me just illustrate a couple of these. This person had interrupted left pulmonary artery. This is a failure of the mediastinal component of pulmonary artery to link up with the lung component of pulmonary artery. So you have kind of a blind end on your mediastinal pulmonary artery. And this is systemic artery coming into the lung from the pulmonary ligament and just fanning out through the lung. And the blood usually connects with the pulmonary arterial system and then drains to the pulmonary venous system. This is the sequestration case that I've already shown you, with a systemic artery coming off the abdominal aorta. And this is an example of scimitar. Here is the abnormal vein, the scimitar vein, this curved vein looking like a scimitar that drains to the inferior, drains the right lung to the inferior vena cava. And here is a systemic artery coming from the abdominal aorta and branching out in the right lung base. So you may see systemic arterial supply in conjunction with scimitar syndrome. So scimitar and systemic artery supply may go together. Don't have to have an anomalous artery. Okay, and then let's talk about systemic arterial supply without sequestration. It's often asymptomatic. It could cause heart enlargement because it is a left to right shunt. So the heart's doing some extra work because there's kind of some wasted circulation. The artery usually comes from thoracic or abdominal aorta, and it's probably more common than recognized. It may be an incidental finding on CT done for some other reason. So here's an example from Jeff Caney in Wisconsin of a big artery coming off the thoracic aorta and feeding into this right lung base here. And you can see these enlarged arteries down here because there's systemic artery coming in to perfuse. Here's that big chunk of that proximal vessel that we see here on the 3D view. So all these abnormal little vessels here are systemic arterialization of that right lung base. There was no other congenital abnormality. This is not sequestration, for instance. And I could show you some other examples of that, but we'll go on to pulmonary sling. We'll start talking about, well, this is a vascular condition that has an airway consequence. So the left pulmonary artery normally arises from the main pulmonary artery, but in this condition, the left pulmonary artery arises from the right pulmonary artery. The right pulmonary artery heads off to the right, and then all at once it gives posteriorly a little branch that swings back across the mediastinum to get to the left lung. And it goes between the trachea and the esophagus in doing that. This is very often associated with airway problems. And the case I'll show you does have airway problems, actually had airway symptoms. And besides having a hypoplastic or a narrowed trachea, there may be complete tracheal rings. Normally the tracheal cartilages are horseshoe shaped and there's a membrane posteriorly. In this case, the rings can go all the way around. So this young man, 16 years old, has chronic stridor and a history of asthma. He's got this kind of narrow upper mediastinum, nothing obviously wrong. Trachea looks okay at this level, but look on the lateral view here. And this is the airway. This should be nice fat trachea going down to the left main bronchus down here, but it looks kind of narrow. So this should be about an inch or so, and it looks more like half an inch or less. So this is the only clue on lateral view that there's anything here, and nobody picks this up in retrospect, me included. So I see this in nobody picks it up in prospect, but I'm really good at retrospect because now I recognize this narrow component of airway here. And also notice the kind of funky upper ribs here. I don't know whether these are cervical ribs or hypoplastic first ribs. So there are a few little weirdnesses. Here is that main pulmonary artery. Here's the right pulmonary artery going into right lung. And here's the left pulmonary artery arising from the back of the right pulmonary artery and going across into left lung. Here is that spindly airway that we were seeing. So this is too small to be a normal trachea. You would not want this. You would not want this to be your trachea. And so here is our sling. So it's called sling because it sort of loops around the airway like that. And here's what it looks like here. The airway is reconstructed here. Here is a normal, pretty normal looking trachea, except that there are complete tracheal rings that go all the way around. Here is a branch that goes into the upper part of the right lung. And then we have this spindly thing here. This doesn't really, this is not a normal continuation down here. And then we have the actual carina down here. That's really weird. And that goes to right and to left lungs, but it's really this narrowed spindly segment. This is called a bridging bronchus. So this malformation here is can be seen with this condition of pulmonary sling. And our sling is actually going around this segment. This is that narrow little hole that the right pulmonary artery gave rise to left pulmonary artery, and it swung around this segment right here. Okay, so we've got this bronchial weirdness in addition to the arterial weirdness. Now, a much more common condition, pulmonary sling is pretty rare, is tracheal bronchus, or used to be called pig bronchus or bronchus suis, the Latin for pig bronchus. And this is a bronchus that comes directly off the trachea or comes off the very proximal right airway. So here is an example of this tracheal bronchus going into a portion of the right upper lung, and then the main part of the right upper low bronchus comes off separately and lower. And typically the right bronchus comes off at about the level of the carina, but with bronchus suis here, pig bronchus or tracheal bronchus, when you have this component going into the upper lung, you often displace the main component down lower. So if you split the difference between these two, that's where the trachea, I mean, the right upper low bronchus would normally be. So the main moiety tends to be displaced lower in this condition. So, you know, this can cause symptoms. It's a small bronchus, and so it's easily occluded or something like that. It could promote infection, for instance, or atelectasis. Or if you were intubated, you might get atelectasis there because the endotracheal tube would be blocking the origin of this. So you could get some consequences of having one of these pig bronchi. But for the most part, it's an incidental finding. In this case, it's very hard to pick up on plain radiographs. So in this case, I don't see any manifestations of tracheal bronchus here. I don't see any manifestations of azygos lobe either. And it turns out that both are present here on CT. So here's our azygos lobe, where the azygos vein is embedded in lung here, rather than just being in mediastinum. And here's our tracheal bronchus coming off nice and high. And then farther down, we have a more normal looking rest of the right upper lobe bronchus, maybe a little smaller than normal. And then here it is on the coronal reconstruction. And you can see that this tracheal bronchus comes off here, and then the right upper lobe bronchus is coming off quite low. It should normally be higher at the level of the carina. So once again, if you split the difference here, that's where the right upper lobe bronchus would normally be. Here it is on a MIP view going into the tracheal bronchus up here, and then the main moiety displaced somewhat lower. Okay, and another condition that causes actually a lot of confusion is congenital bronchial atresia or stenosis. And this is typically a left upper lobe phenomenon. And we get this little bullet-shaped tumor. So these things are usually thought to be tumors. Notice that there's a lot of surrounding lucency of the lung here. So we have air trapping around this because this is an obstructed bronchus. This is a mucus plug that is formed because proximally there is a stenosis at the origin of this branch. So here it is on this ancient CT scan with the air trapping here. And if we could measure Hounsfield units, we'd be able to say that this is lowish attenuation corresponding to mucus. So it's not as dense as normal tissue, and it's denser than water. So this is a classic bronchial atresia. It's a left upper lobe phenomenon usually, but it can occur elsewhere, as I will show you. So I've seen these people get pulmonary angiograms and CTs and biopsies and everything like that. If you recognize this and the findings, then it's usually pretty straightforward. So it's a retained mucus is what we see. That's what forms the visible plug, the mucocele. The lung gets aerated and gets hyperaerated by collateral drift. So we see the hyperlucency. The mucus plug can be ovoid, bullet-shaped, branching. It could be cystic with a fluid level. So I've shown you sort of an ovoid or branching version. Now, we have seen these things elsewhere, and the most common second location in my experience is right lower lobe. And here we've got this giant mucus plug down here surrounding hyperlucent lung because of air trapping and collateral drift. And measuring Hounsfield units here, we'd probably get some low value, around maybe less than 20. And here's another example, again, right lower lobe, big fat mucus plugs surrounding hyperlucency and 13 Hounsfield units of mucus, not soft tissue. So this situation, this right lower lobe situation, supposed to be unusual, but I have these two cases. Here's a right upper lung manifestation, this little bullet-shaped thing here. Here it is on CT surrounding hyperlucency, 13 Hounsfield units, mucus plug, and this is a congenital bronchial atresia on the right. So left upper lobe is most common, but other locations are also okay. So congenital bronchial atresia, you have to worry that the mucus plug is being caused by something other than a congenital stenosis. So you have to worry about tumor in particular. So it's necessary, I think, to do bronchoscopy in these people and make sure that there's not a tumor. So bronchoscopy is mandatory, I think. But the bronchoscopic finding is that there is no finding, because I had assumed that there was a wall in a bronchus, that you'd be going down a bronchus and suddenly you'd come to a wall, and that was the congenital stenosis. But it turns out that that wall is actually where that branch originates. So it's really at the bifurcation, and therefore it looks like the normal bronchial wall, and the other branch, the bronchoscopist just goes down the other branch. He is not aware that there was a branch hiding behind a wall, what looked like a normal wall to him. There was actually an origin of a branch there. So the bronchoscopic finding in a number of these cases is no finding, but that's good. At least there was not a tumor. So at that point, I think you've done the bronchoscopy, you don't see a tumor, then you can proceed with either leaving it alone or resecting it if there's some reason to do that. A couple of other airway conditions, congenital lobar overinflation. Doesn't have to be lobar. It used to be called congenital lobar emphysema. And this person has lots of air trapping. You can see the mediastinum has gone off to the right. The left lung is black. The vessels are spindly. These are all signs of air trapping in this lung. It's puffed up. So this person has quite a large lesion in the left upper lung, and that's the most common location, just as it is for congenital bronchial atresia. This affects more guys than gals, and it's attributed to a cartilage deficiency. That's what people will say. And here's what it looks like on CT. You see this hyperinflation here, spindly vessels. And then you see this little, you don't see a mucus plug. So that's the difference between this and congenital bronchial atresia is you don't see a mucus plug. You just see this tissue here, and these are vessels. So congenital lobar hyperinflation, and it doesn't have to be the whole lobe. And then we'll go on to CPAM, used to be called CCAM, congenital cystic adenomatoid malformation. It's now congenital pulmonary airway malformation. You see this bubbly stuff here in the left lower lobe, lots of walls of cysts down here, and it's a bit overinflated down there. So this is a cystic mass of lung tissue. Here's what it looks like on CT, this bubbly stuff. It's pretty extensive in this case. This is a type 1, which is the big cysts, large cysts, 2 to 10 centimeters. This is the most common form. And then here is a big cyst that is complicated by pneumothorax. And here's actually some liquid down here. So this is a hydropneumothorax because of rupture. I don't know whether there was another cyst that popped, but we have one huge cyst down here. So this again is type 1 because of the big cyst greater than 2 centimeters. Here is type 2 with cysts less than 2 centimeters for the most part. And then the least common is type 3, which I don't have an example of, and that tends to be more symptomatic, involves lots of lung tissue. So this is type 2 here with cysts 2 centimeters or less, and this is the second most common. And then here is extensive cystic abnormality throughout the whole left lung, and it's very hypoplastic. The mediastinum has shifted way to the left because of the low volume of this abnormal dysplastic lung, and the right lung has been dragged across the midline like this. So it's come way across because the anterior junction line has rotated way around there. So this is another case of CPAM that's very advanced and has really taken out the entire left lung. But it's not microcystic, so I don't think it's type 3. Okay, our last condition is left lung isomerism, and this is an airway condition that usually doesn't have any symptoms associated with it. The right lung, it becomes a mirror image of the left lung. So a normal left lung has 2 lobes, not 3, the way a right lung has. And the bronchus is underneath the artery. So the pulmonary artery goes over its bronchus in the left lung. It's associated with polysplenia and congenital heart disease in some cases, but it can be isolated. And a number of cases I've seen have been just isolated. It's an incidental finding that you wouldn't have picked up without CT scans. It's more often recognized in the past because of CT, and it's usually benign. So here's an example. This person has this symmetry of the bronchi here on the coronal. If you look at this part of the lung here, you see this symmetry between the left and the right. The bronchial systems are the same. The pulmonary artery, the right pulmonary artery is going over its bronchus here, the way the left pulmonary artery goes over its bronchus. So here's left pulmonary artery going over this bronchus. Right pulmonary artery is now also going over its bronchus, imitating the left side as a mirror image. So this is isolated left lung isomerism, meaning left lung isomerism without other sinus abnormalities, such as polysplenia. Here's a nice example of this symmetry here. So the normal left bronchus is a very long bronchus. It goes a long, long way without any branches, and then it goes into its lung. The normal right bronchus has a right upper lobe bronchus almost immediately, almost at the level of the carina. And so we have immediate branching. So with a left lung, we expect a long unbranched bronchus, and indeed we have that now on the right. And we have the pulmonary arteries going over their bronchi. And this person also has sarcoid. That's what all this lymphadenopathy is. So we have symmetry here of the airways. We've got right pulmonary artery going over its bronchus, thinking it's a left pulmonary artery. Here's left pulmonary artery going over its bronchus. That's a good thing for a left bronchus. It's not normal for a right bronchus. So this is left lung isomerism. And the person has sarcoid too. And normal relationships between liver and spleen. So we don't have polysplenia or any other situs abnormality, just isolated left lung isomerism here. Okay, we've covered a lot of ground. We've covered some airway and some vascular congenital lesions you may acquire in adults and young people. So we have time for a few questions if there are any, or if you're exhausted, you can stand up and take a break and massage those legs so you don't get clots and pulmonary emboli. We don't want that on a thoracic lecture. Any questions? Okay. Well, thank you, everyone. Happy second hour, and for the new people, welcome to the UW residency, and we're here to help you. Thanks, everyone.
Thank you, Dr. Garza.
Thank you.
Thank you.
Thank you.
Thank you.
Marcus, can you hear me?
Yes, I can.
Okay, is it clear or?
Oh, yeah. Yeah, you're coming through loud and clear.
Dr.
Okay.
Godwin finished up just a couple minutes ago. I think you can start anytime.
Oh, okay, great.
Just double check for me that you can share the screen. I think I have you set as co-host, so it shouldn't be a problem. Great, that works fine.
Thanks a lot, everyone, for being here. Hopefully you're having a good afternoon. And today, the second lecture for today is interstitial lung disease and how, as radiologists, we should approach interstitial lung diseases. To begin with, interstitial lung disease in itself is a misnomer. These are actually diffuse parenchymal lung diseases, and some diseases actually have small airway component too. Say, for example, hypersensitivity pneumonitis. It not only has a parenchymal lung disease component, but it also has a small airway disease component. And we often look to small airway disease component, which is central lobular nodules or air trapping, to include that particular differential. So, but the term is very catchy. It's always been there. So we just continue to use the term interstitial lung disease. And I'm actually going to focus on imaging clues, really the signs that are important for us to recognize so that we can interpret images in a particular way when those particular signs are present. Otherwise, it is usually a combined game, meaning both the radiologist, pathologist, and the interstitial lung disease pulmonologist, when they sit together, and sometimes even the rheumatologist and occupational lung disease individuals, we sit together and do a multidisciplinary conference where we come to a working diagnosis. So sometimes it's not just the ball is just not in our court. And let's start. So I don't have any disclosures, which is great. And the objectives of this talk are going to be to learn imaging approach to ILD and also learn the diagnostic process of these conditions. Have you seen this before? This is a regular feature in most of my talks. And what this is a Fagan's nomogram. And what it does is it connects the pretest probability with post-test probability. And generally, we are looking for signs that have a likelihood ratio that is more than 3. That helps us include a particular diagnosis. So if there is a sign, if the positive likelihood ratio for that particular imaging sign is more than 3, generally our post-test probability is good enough for us to say that we are reasonably confident that this is a particular diagnosis that we are dealing with. So the crux of HRCT diagnosis of interstitial lung disease revolves around the diagnosis of idiopathic pulmonary fibrosis. And the imaging and histologic pattern in idiopathic pulmonary fibrosis is that of usual interstitial pneumonia. So we are always trying to focus on, am I dealing with UIP or not? So you begin with UIP. What exactly are the HRCT features of UIP? You have reticulation, you have subpleural lung predominance in terms of axial distribution. And then in terms of craniocaudal distribution, it tends to be basal lung predominant. But the distribution can sometimes be heterogeneous. And another important feature in order for you to call UIP is that honeycombing needs to be present. And honeycombing is a required feature for you to call something as UIP. Whereas if there is no honeycombing and all the other features are present, then you at least need traction bronchiectasis or bronchioloectasis for you to call it probable UIP. And if you don't have any features of architectural distortion, by architectural distortion, we mean honeycombing, traction bronchiectasis and bronchioloectasis, and also lobar volume loss. If you don't see any of those features and all you're seeing is some reticular abnormality or crisscrossing of lines without architectural distortion in the expected distribution, that is subpleural and basal predominant distribution, then you categorize it as indeterminate for UIP. Intuitively, if HRCT pattern is that of UIP, then the probability of histologic pattern being UIP is more than 90%. And if it's probable UIP, it goes anywhere from 71 through 90%. And whereas indeterminate for UIP is anywhere from 51 to 69% probability of finding UIP at histology. And if you don't see this particular spectrum of patterns, then everything else falls under the category of alternative diagnosis, meaning the probability of it being UIP at histology is really low. So what are those features? Like, you have multiple lung cysts, you have marked mosaic attenuation, ground glass opacity is the predominating feature. There are multiple micronodules, it's a central lobular nodular disease, so on and so forth. Pretty much everything else falls under that category. So let's look at this. What is the histology pattern of IPF? Anyone? Maybe let me see if the chat, I guess chat option is not available. So we'll just skip the chat component. So what is the histology pattern of IPF? It is UIP. And using HRCT, what are we trying to predict that, what are we trying to say that this individual, particular individual has at histology? It is UIP. So if you have classic UIP pattern on HRCT, the probability of UIP at histology is more than 90%. That is the basic thing. And in IPF, the histopathologic feature of IPF is UIP. But unfortunately, UIP is not specific for or unique for IPF alone. So UIP can be seen in other conditions as well. It can be seen in autoimmune disease or connective tissue diseases. It can be seen with chronic hypersensitivity pneumonitis. It's been described in asbestosis. It can be seen with certain drug-induced lung diseases like bleomycin or busulfan, those kinds of situations. So which means that if you have a classic UIP pattern, majority of them are going to be IPF, but a minor percentage of them are going to be something else. Right. So as we already kind of, I alluded to this, HRCT patterns and their probability of UIP at histology. So if you see an HRCT pattern that is UIP, then there is a more than 90% chance that you are going to find UIP at histology. If you see a probable UIP pattern, which is all the features without honeycombing, then the probability is going to be anywhere from 71 to 89%. And for indeterminate UIP, it is 51, just above chance to up to 70% chance that you're going to encounter UIP at histology. So if you were a pulmonary medicine specialist, what would you accept as a therapeutic or rather treatment threshold? So in which of these situations are you not going to do biopsy? Probably in this situation, right? So if you see UIP at HRCT, you don't need to do a biopsy. And depending on the clinical situation and patient preference, even in probable UIP, you can use clinical features to say that maybe this individual has IPF, or if the individual has autoimmune features, you go down a different path. So UIP and probable UIP, these are the two sets in which you may forego doing a biopsy, which is why it becomes important for us to recognize that. In all the others, the referring provider has the option of doing a biopsy. If you call it alternate diagnosis, they may do lavage, they may do biopsy, they can do anything. But if you call UIP, and if they still have to do biopsy, they have to really justify doing a biopsy, because your post-test probability is really high for UIP at histology. And even if you don't figure out the etiology, just HRCT categorization itself predicts survival. As you can see, UIP pattern, if you call it UIP pattern, then the prognosis is really bad. As the time passes, the number of individuals who survive is going to be pretty low. And the probable UIP is also close to UIP, but not exactly like UIP, because some of the fibrotic NSIP patients would be in this category. And whereas indeterminate UIP compared to UIP does much better, and everybody else does much, much better, as you can see. So now the other aspect of learning HRCT diagnosis of interstitial lung disease is to figure out specific interstitial lung diseases and their patterns. Say, for example, somebody has sarcoid that has a specific imaging signature. So we should be able to figure that particular thing out. And the way we have formally done lots of studies with UIP, IPF, we don't have that many studies highlighting the likelihood ratios for individual signs in some of these other diseases. So maybe because the diagnosis is pretty intuitive in some of these conditions and pretty classic, that we didn't really embark upon doing a formal study to kind of say that, let's say if you see a galaxy sign, the probability of it being sarcoid at histology and so and so. It has not been really formally studied like that. So effectively, we have a lot of signs and we accept that they indicate a particular interstitial lung disease, but you can't really assign numbers to those. So as we go through each of these individual cases, case examples, you'll understand what I'm trying to say. So let's look at this image. What is the diagnosis here? So let's see. Interesting. Do we not have a chat option anymore, Marcus? Looks like no. All right, so never mind. And maybe one of you, some of you bold souls can shout out the answer, because I cannot recognize your voice anyway. So
Looks like there's honeycombing.
excellent.
So I'm thinking UIP.
So there is reticulation, there is basal predominance, there is subpleural predominance, and there is honeycombing. So as you said, this is indeed UIP, right? And here's another example of UIP where you have peripheral lung predominance. You see nice reticulation. And actually, there's a lot of honeycombing in this particular individual, but there's also some reticulation in relation to honeycombing here. And again, the distribution is quite peripheral and nothing else predominating. And we do have a little bit of emphysema in the upper lungs. So you can sometimes see emphysema in the upper lungs, especially in individuals who develop IPF and happen to be cigarette smokers. So how do you know that you're not dealing with emphysema with a little bit of fibrosis and you're dealing with IPF with a little bit of emphysema? You go by the abnormality that is predominating, right? In this case, you can notice that lung fibrosis is the predominant feature here. And so you're probably going to say that this individual has lung fibrosis with upper lung emphysema, although both the elements both the components of functional impairment will be there when you look for pulmonary function test abnormalities. So now we move on to signs or imaging signs in interstitial lung disease. So let's start with this one. Does anyone know what sign we are trying to show here? So we have bilateral lower lung, relatively homogeneous abnormality, a combination of ground glass opacity and reticulation. And what we do notice that's really interesting.
Plural sparing.
Subpleural sparing, right? So, and what else do you see? Is there any additional imaging sign that you see here besides subpleural sparing? Another interesting imaging sign that you tend to see in individuals with NSIP is what is called spatial homogeneity, meaning if you look at the abnormality in the right lung and look at the abnormality in the left lung, they're almost identical. So if you take a piece of lung from right lung and plug it into the left lung, you won't notice any difference because the pattern or the type of abnormalities are so similar. So spatially, the type of abnormality is going to be very uniform. It may not be uniformly distributed, but the type of abnormality is very similar. And also notice the symmetry. So that's exactly what we mean. So very identical in terms of the type of abnormality. Another interesting thing that we see with NSIP, besides subpleural sparing and spatial homogeneity, is temporal homogeneity, meaning the abnormalities run at same pace in terms of evolution. Meaning, like if you have ground glass opacity today in the right lung and also in the left lung, 3 years later on both sides, you will see similar amounts of reticulation if it progresses. So let's look at this particular example here. So you can see that there was mostly ground glass with early reticulation, but then as time passes, almost after 3 years, you start noticing more of reticulation, and there is also traction bronchiectasis, and the spatial homogeneity is maintained and the temporal homogeneity is also maintained, which is a unique feature for NSIP. And this is one of the ways you can differentiate NSIP from UIP, because UIP is neither spatially homogeneous nor temporally homogeneous. It tends to be heterogeneous because some areas, like say, for example, if this were to be UIP, the left lung would have developed honeycombing, whereas the right lung would have been still in the early reticular phase. Is that clear? Okay. No answer. I assume that it's clear. And then here's a coronal image also showing that temporal homogeneity. And we are seeing mostly ground glass, a bit of reticulation here. And a few years later, we see mostly reticulation interspersed with ground glass opacity. So there are two images of traffic here. Which image do you think metaphorically represents NSIP, and which image do you guys think represents UIP? Which one is homogeneous? Huh?
Screen left is NSIP.
Excellent. So the image on the right is so heterogeneous that the pedestrian is right by the dangerous bus, meaning like normal lung, very close to honeycombing, and which is what we tend to see with UIP. And accordingly, prognosis tends to be worse with UIP. And moving on to this particular case, what imaging sign are we seeing here? So we are seeing some basal ground glass opacity and a little bit of reticular abnormality in this location, but there is something else that is glaring at us. What are all these? These are the
Cysts.
cysts. Excellent. So what is interesting about these cysts? Let's say if I were to say that this is lymphangioliomyomatosis, why would you say, no, this is not lymphangioliomyomatosis?
They're not regular.
So they're of variable size, number one. Number two, the rest of the lung parenchyma is not normal. The intervening lung parenchyma is also abnormal. So there is some things going on. The size of the cysts is variable, although they're all spherical. And some of these cysts are very close to the blood vessels. So, one of the description for cysts in the setting of LIP is that they tend to be perivascular. When a cyst is this big, it is probably going to be close to one of the blood vessels. So I've never found that as useful. but variability in size of these cysts is quite useful in suggesting that maybe we are dealing with LIP. And what's interesting about lung cysts is that there are only few lung diseases which give you lung cysts. I mean, you can see them normally in normal individuals, but when it is part of a disease, you can see it with LIP, lymphangiomatosis, discoemetic interstitial pneumonia. Then rarely you may see some cysts in hypersensitivity pneumonitis, and also some rarer conditions like Birt-Hogg-Dubé syndrome. Also, you can see lung cysts. But in that condition, you actually see the shape of the cysts tend to be lenticular or oblong in shape. Good. So let's see what this particular individual has. So this person has ground glass opacity and reticulation, has lung cysts, which are of variable size and maybe perivascular, and this person happens to have Sjogren's. So what should be our diagnosis?
LIP.
LIP, right? So in Sjogren's, we get lymphoid interstitial pneumonia. And with this kind of interesting combination, you should think about LIP. And here's another example where we are seeing ground glass opacity and we are seeing these tiny cysts. Do you notice these little cysts? But what is interesting is in the normal areas of the lung, you don't see any cysts. Only in the areas where we are seeing ground glass opacity, we are able to see cysts. This is unique to discoemetic interstitial pneumonia, where you see these little tiny cysts, which are only in abnormal attenuating areas. And some people think that maybe these are early areas of early emphysema, and you're able to see them better because there is change in background. Maybe there are some areas of subtle emphysema in the normal lung as well, but because the background is not high density enough, you're not able to see them. Whereas in areas where there is high density, you start noticing them. That is a hypothesis, but this is a unique feature in itself. So the key number one, what is the sign that we are looking for? We are looking for cysts. Cysts are present and they're present only in abnormal areas. So we are going to think of discoemetic interstitial pneumonia or DIP. And DIP is exclusively seen in individuals who do what to themselves?
Smoke.
Oh, can you get it with marijuana? The answer is no. So it has to be cigarette smoke alone. And rarely it can be associated with autoimmune disease, especially in children. Children who have autoimmune disease can rarely develop discoemetic interstitial pneumonia. Are you all with me so far? Let me know if I'm going too fast. There are lots of signs. All right. Okay. The next sign is something to do with what you may find in your backyard, or maybe sometimes even in your front yard. So which sign are we referring to here? This is a nice, beautiful combination of ground glass opacity and some interlobular and intralobular interstitial thickening. And so what sign are we referring to here?
This is
Crazy
the
paving.
crazy.
Paving, excellent. So crazy paving and another sign. There is another sign here besides crazy paving. It has something to do with the distribution of the abnormality. So the distribution of abnormality here is described as geographic distribution, as if this is a piece of landmass in a sea of water. So you can actually have a really narrow zone of transition between normal and abnormal lung. That is sometimes described as geographic distribution. If you see crazy paving, if you see geographic distribution in a relatively younger individual with minimal symptoms, then you should think about what proteinosis.
Alveolar.
Alveolar.
Pulmonary alveolar proteinosis, excellent. You know, this is my style of taking small breaks because I am talking a lot. So, all right, let's see. So this is what we mean by crazy paving, and that is a unique feature. Unfortunately, it is not specific for pulmonary alveolar proteinosis. It can be seen in almost any of the alveolar filling processes, but the geographic distribution, middle-aged individuals, usually men, that is relatively characteristic for pulmonary alveolar proteinosis. And there are other conditions like, silicoproteinosis or acute silicosis, exogenous lipoid pneumonia. These are acute exogenous lipoid pneumonia, not the chronic ones where you get the fat density in lung consolidation. These are some of the interesting ones where you see crazy paving. You can also see crazy paving whenever you have septal thickening and ground glass opacity, which is cardiogenic pulmonary edema. You can also see in slightly later phases of diffuse alveolar hemorrhage. In the early phases of alveolar hemorrhage, you generally don't see the interlobular septal thickening when the patient presents. And then can somebody tell me an infection where you can get crazy paving pattern in an HIV positive individual?
PJP pneumonia.
Excellent. All right. So here's another example. Sorry, it's a little bit of an old digitized image, but you get the point. So you not only have crazy paving pattern, but you also have this geographic distribution, which is unique to pulmonary alveolar proteinosis. So what about this one here? What is the imaging sign that we are trying to show here? So let me describe the finding. So you see ground glass opacity in the center and a peripheral tiny rind of consolidation.
Reverse halo, atoll.
Reverse halo sign. So is this a reverse halo sign or an atoll sign?
Reverse halo.
So reverse halo is the umbrella term, and you can see more intense abnormalities sometimes, which are also called as reverse halo. Say, for example, bird's nest sign in invasive mucormycosis. Say, for example, angioinvasive mucormycosis can give you bird's nest sign. A pulmonary infarct can give you a reverse halo as well. But this soft reverse halo that we are seeing here, mostly ground glass with a subtle pencil line of consolidation around the ground glass opacity and bilateral. So usually in parenchymal lung, diffuse parenchymal lung diseases such as organizing pneumonia or eosinophilic pneumonia, reverse halo is not going to be unifocal. It's going to be bilateral, because it is usually the nature of the pathogenesis of this particular condition is such that it is a multifocal disease or a diffuse parenchymal lung disease. So you see it bilaterally, and this is a very soft reverse halo sign. And when you see such a soft reverse halo sign, you should think of atoll sign. And atoll sign is unique to organizing pneumonia and eosinophilic pneumonia. It has also been described in other conditions, but I think for your level, you should remember this particular association. If it looks more intense, if you see a thicker rind of lung consolidation with central, almost necrotic appearing ground glass opacity in the center, then you move away from the standard organizing pneumonia, eosinophilic pneumonia / atoll sign. You should start thinking about a more aggressive process like mucormycosis or invasive fungal infection or even a pulmonary infarct. Is that clear? Okay, good. So 20 days later, this abnormality completely clears without any treatment. So sometimes organizing pneumonia can resolve spontaneously, although majority of them do require corticosteroid treatment, and majority of those actually melt away once you start them on steroids. Very rarely, organizing pneumonia patients can have a residual abnormality, or it can be steroid dependent. You stop corticosteroids, it comes back. You start corticosteroids, it goes away. And in those situations, then you look for alternative treatments. And rarely it can be steroid resistant, meaning even when you give corticosteroids, it may not go away. Is that clear? Okay, excellent. So what sign are we trying to show here? Is the same sign, And you can actually see a reverse halo here and reverse halo here. And then you also have this nice, beautiful peribronchovascular distribution. You can see that it goes up to the pleural surface, but majority of the disease is hugging the airways. You can see this. This is hugging the airways, hugging the airways. So when you see this kind of a pattern where it is consolidative / ground glass opacity pattern with atoll sign or reverse halo sign, you should think about organizing pneumonia, because organizing pneumonia can be subpleural in distribution majority of the times, but it can also be peribronchovascular in distribution. What is interesting is peribronchovascular distribution of organizing pneumonia is more often seen with a particular autoimmune disease, which is the polymyositis, dermatomyositis. Let's say you saw this image, you're thinking of organizing pneumonia, then you should start wondering, maybe this individual has an inflammatory myopathy or an autoimmune myopathy, and which this individual did have. And the zoomed up image actually shows atoll sign really well. So atoll sign, think organizing pneumonia, but could also be eosinophilic pneumonia. So what is the difference in terms of craniocaudal distribution between organizing pneumonia and eosinophilic pneumonia? Which one is lower lung predominant? So when it's just 50-50, it's always good to take the chance.
Organizing.
Organizing pneumonia is lower lung predominant, and accordingly, eosinophilic pneumonia is most often upper lung predominant. And these are all guidelines. These are not absolute rules. So, you know, sometimes you may have an eosinophilic pneumonia that is lower lung predominant. So keep that in the back of your mind. Okay, now we move to some of these interesting signs. And if you know Latin, you can probably predict the name of the sign. And so what sign are we trying to suggest based on this image? Let me tell you what all we are seeing. We are seeing air trapping, we are seeing ground glass opacity, and we are also seeing normal lung density.
Head cheese.
Head cheese sign. So we, which is a very catchy term, and we've been using it for many, many years. But now we have moved away from that, and because internationally, you know, head cheese is not known to many people. So the consensus statement now requests us to use the term 3-density or triple density sign, which basically is pretty intuitive. You have air trapping density, you have ground glass opacity density, and also normal lung density. When you see that triple combo, start thinking about which disease. Which disease should you think of when you see head cheese sign or triple density sign?
HS.
Hypersensitivity pneumonitis. What if this individual happens to be a cigarette smoker? Then which disease would you think of? Then you should think about respiratory bronchiolitis. And luckily, most individuals with hypersensitivity pneumonitis happen to be never smokers, so which is a good clinical clue to have. So here's another example of this triple density where you're seeing areas of air trapping, relatively normal density, and also ground glass opacity. And what's interesting is this person decided not to give up his birds, and a few years later ended up developing something that looks like this. So what's the difference between this and this? So this is acute / subacute hypersensitivity pneumonitis, and without treatment or without effective treatment or without removing the antigen from the environment, lung fibrosis may ensue, and which is what this person developed. And what's interesting is if you see lung fibrosis, along with that, if you see areas of air trapping or mosaic attenuation, and if it's significant amounts, then you should think about hypersensitivity pneumonitis. This imaging pattern is reasonably specific for hypersensitivity pneumonitis. The alternate situation where you can see this is smoking related lung fibrosis. What about this one here? What sign are we trying to show on this image?
Tree and bud nodules.
So, but some of these nodules are along the fissure. So,
Oh,
a bronchiole is not a Schrodinger's cat, right? So it cannot be in the center of the lobule and also the periphery of the lobule. So if you're seeing, sorry, so if the nodules are on the pleural surface, then it cannot be centrilobular.
how about peribronchovascular nodules?
Yeah, there are peribronchovascular nodules, but we don't have that option. There are only 3 options when you see small nodules. You have centrilobular option, you have perilymphatic option, and then you have random option.
Number 2.
Number
perilymphatic.
2, perilymphatic, excellent. So these are, and one simple thing to remember is you see multiple small nodules. Question number 1, are they along the fissures or pleural surface? If the answer is yes, then it cannot be centrilobular. But then how do you differentiate random from perilymphatic nodules? What you do is you see if these nodules are clustering. If they're clustering, if they're coming together and are non-uniformly distributed, then you are probably dealing with perilymphatic nodules. If these were randomly distributed, they will be uniformly distributed everywhere. So which is why they're clustering on the bronchovascular bundles, because your answer peribronchovascular is also correct, because lymphatics run over the bronchovascular bundles also, besides being rich in the periphery of the lung. So which is why you tend to see this clusters of nodules on the bronchovascular bundles. But that is one aspect of making this diagnosis. But what about this one? This cluster of nodules looks like what spatial structure?
Galaxy.
Galaxy, excellent. So this looks like a galaxy. So this is also called a galaxy sign. And this is unique to the individuals with sarcoidosis. And so step number 1, this individual has multiple small nodules. Step number 2 has perilymphatic distribution and also has the galaxy sign. So this individual probably has sarcoidosis. And then you could say, why can't this individual have lymphangitic carcinomatosis? Typically, you don't see a galaxy sign with lymphangitic carcinomatosis. You tend to see nodular interlobular septal thickening and peribronchovascular nodular cuffing, which is usually intense. Another interesting clinical clue between sarcoid and lymphangitic spread of tumor is if you have lymphangitic spread of tumor, the patient will be quite symptomatic. Whereas sarcoid, generally in the nodular phase, is not as symptomatic. Okay, this next sign is something to do with what you may have at breakfast. So let's see. What sign are we dealing with here?
Cheerios.
Cheerios, excellent. So what are we calling Cheerios? So we're calling Cheerios these little rounded densities with central lucency. They look exactly like Cheerios. And besides Cheerios, you're also seeing some regular nodules. So when you see nodules and Cheerios in a cigarette smoker with relative sparing of the lung basis, you should think about pulmonary
Langerhans cell
histiocytosis. Excellent. So that is what Cheerio sign is all about. And as the disease progresses, these Cheerios will form into bizarre shaped cysts, which are really irregular shaped cysts. And the reason they look like Cheerios is because the pulmonary Langerhans cells are infiltrating around and in the wall of the airway, and the airway is dilating. So when you cut through the airway, it almost looks like a nice uniformly thick-walled airway, which is why it looks like that nice, beautiful Cheerio. Okay, we are changing gears a little bit, and the next set of signs are actually signs that help you predict a particular etiology in the setting of UIP. So all these patients have UIP, or usual interstitial pneumonia pattern, but within UIP, the distribution or the type of abnormality is such that you can predict a particular etiology. So here it says anguli quatar. Okay, so what exactly are we trying to say? Let me describe, maybe you'll get the sign. And this is, you have honeycombing in this location, in the anterolateral location on both sides, and also posteriorly on both sides. So this looks very much like a propeller blade sign, but propeller blade doesn't sound anything like anguli qatar, right? So the other name for this is the four corner sign. So four corner sign is another thing, another interesting sign that helps you differentiate UIP from autoimmune disease from UIP from other causes. Meaning if you see this four corner sign or the propeller blade sign, think of autoimmune disease as the cause. And here's another example where we are seeing anterior upper lobe sign. This is anterior upper lobe sign. And together, you can call that a four corner sign as well. And this one says Nemium favus mellis. Let's see, what are we trying to show? So what do you see here? What abnormality are you seeing here? Are you seeing microcystic honeycombing or macrocystic honeycombing? Or are you seeing little bit of honeycombing or exuberant honeycombing?
Exuberant.
Exuberant honeycombing, and that's what is the name of the sign. When you see only honeycombing, that also indicates an autoimmune etiology. More specifically, within autoimmune etiology, it often points to rheumatoid arthritis, and that's a useful sign. So you don't see any other features of fibrosis. All you're seeing is a sea of macrocystic honeycombing. And here's another example from our star former resident, Jonathan Chung. Let's see. And this one is recta acies. And let's see, what exactly are we trying to see? This person also has exuberant honeycombing. Why are we calling this recta acies? What is interesting about this particular sign is that between the normal and the abnormal lung, you can draw a line. So a straight edge, when you have a straight edge to the abnormality in the lung, especially on a coronal image, you should call it the straight edge sign, which is also a sign that indicates UIP in the setting of autoimmune disease. So these are all signs, when present, should make you think about autoimmune disease. And what is interesting is you can actually see for the anterior upper lobe sign, the specificity is 87.2% and has a positive likelihood ratio of about 2, but the sensitivity is really low. So all these signs, the sensitivity is low, but the specificity is high. And some of these signs have high positive likelihood ratios. Say, for example, if you see straight edge sign, probability of it being an autoimmune disease is reasonably high. If you have more than one sign, so in the same individual, you not only have exuberant honeycombing, but also four corner sign or straight edge sign, then the positive likelihood ratio is pretty high, which is excellent. Say, for example, in this individual, we not only have exuberant honeycombing, we also have straight edge sign, and we also have anterior upper lobe or the four corner sign. So you have to suggest autoimmune disease with high confidence as a cause of lung disease in this individual. And what's interesting is if any one of you is interested in kind of putting numbers to some of these signs, which are accepted signs, but we don't have specific numbers. I think that would be a low-hanging fruit in terms of a publication. And some of us do know about these, but then once you study them formally and assign a particular likelihood ratio for these signs, then it'll become common knowledge. And it'll be accepted, better accepted, and then you don't have to do unnecessary investigation. So NEMO, this is apparently a NEMO sign. I guess NEMO means nameless, right? So let's see, what is this nameless sign? So this individual has a peribronchovascular and subpleural predominant lung disease, lower lung predominant disease, and the dominant abnormality is that of consolidation and a little bit of ground glass opacity. So the moment you think of diffuse parenchymal lung disease, which is subpleural and lower lung predominant, and is also peribronchovascular predominant, and consolidation being the main abnormality, you start thinking about organizing pneumonia. So this is the CT that we saw in August of 2019. And then 3 months later, this patient advanced to substantial amount of lung disease. Almost it is appearing like acute interstitial pneumonia or AIP kind of a pattern, right? This is almost like an acute lung injury pattern now. Within 3 months, the interstitial lung disease progressed so rapidly. That is not what we expect with standard organizing pneumonia in the setting of autoimmune disease. So when you see rapidly progressing organizing pneumonia or rapidly progressing NSIP, which goes from NSIP to AIP or OP to AIP within a few months, then you should think about this particular etiology, which is amyopathic dermatomyositis associated interstitial lung disease. And often these individuals who have this rapidly progressive ILD tend to have MDA5 antibody. Anti-MDA5 antibodies are positive in these individuals, and they usually don't tend to do very well. So they need good, quick management, and sometimes you have to put lung transplant on the table sooner than later. So here's our last case of the day, and let's see. I'll let you take a look at this for a few seconds, and then we'll assess what exactly are we seeing here. So what is the dominant abnormality here in this individual? What are we seeing? We are seeing reticulation. We are seeing, although you could say maybe this is diffuse in distribution, maybe not exactly basal predominance, but definitely subpleural predominant. And honeycombing is absent, and I don't even see any traction bronchiectasis or bronchiolectasis. That is also absent. So everything is present. Honeycombing is absent. Architectural distortion is, to say architectural distortion is absent, meaning honeycombing, traction bronchiectasis, and bronchiolectasis are absent. So which should make us call this what? UIP or indeterminate for UIP? So yeah, it's not indeterminate for UIP, it's actually indeterminate UIP. So UIP or indeterminate UIP?
Indeterminate UIP.
Yeah, excellent. So this is indeed indeterminate UIP, and that's where I am going to summarize my talk after this. And did you guys have any questions about some of these signs?
I saw the chart with the specificity, low sensitivity on these UIP signs. What's in the real world and clinical practice, how often do you see some of those?
Oh, you see them reasonably often. I think see, these signs are really useful for us, because then these are the situations, instead of just saying UIP, you're able to predict etiologies.
Mhm.
Can you actually go back to that table as well? Did it say that NSIP with heterogeneity, spatial heterogeneity as well as homogeneity?
Which one was that?
I thought it said NSIP is associated with both spatial heterogeneity and spatial homogeneity.
So this one. So temporal homogeneity, and yeah, this one does say temporal heterogeneity. It shouldn't. This should be UIP. That's we'll have to talk to Dr. Kitchka. Right. Thank you. Good catch. And so in summary, let me show you an algorithm. This is an interesting algorithm that this is how I evaluate HRCT scans, especially for when I'm looking for interstitial lung diseases. So the question number one is, am I dealing with diffuse parenchymal lung disease? Partly this question is answered by the referring provider who wants me to say, well, are you dealing with ILD of some sort or not? So then the first question is it a UIP pattern at HRCT? If the answer is yes, then you see, does this individual fit clinically into the IPF, IPF picture? So who would be an individual who would fit into an IPF picture? An elderly male with progressive shortness of breath and loss of exercise tolerance. That individual with a classic UIP pattern, you don't have to think about anything other than starting antifibrotics. If the answer is yes, you make a diagnosis of IPF and you're done. But if the answer is no, you're not dealing with UIP, then the next question is it probable UIP? If the answer is yes, and the person fits that clinical picture of an elderly male, no other clinical clues in terms of maybe that individual doesn't have birds, is a never smoker and stuff like that, then you can call it IPF and start treating, because remember, it's almost like 71 through 89% post-test probability with probable UIP, right? But if that is also not the case, then the next question is it indeterminate for UIP? If the answer is no, then is there a specific imaging signature on HRCT? Because now once you say that this doesn't fall under the spectrum of UIP, you're automatically calling it alternative diagnosis. And then you're starting to look for, am I dealing with, I mean, generally you don't go in this way in terms of like you would straight away jump to that specific pattern, but this is how you should organize in your mind. So is there a specific imaging pattern? So am I seeing a crazy paving pattern? Am I seeing perilymphatic nodules? Am I seeing, some other interesting sign? If the answer is yes, then you make that specific ILD suggestion on HRCT. If the answer is no, for the specific imaging pattern, and if the answer is yes for indeterminate UIP, then you start looking for clinical clues. Then you really rely heavily on clinical clues. Does the person have birds? Is there a moldy mold exposure? Or is the person cigarette smoker? What about occupation? Is the person getting exposed to beryllium or silica or something else? If the answer is yes, and based on those clinical clues and the imaging pattern and sitting together with other team members, can you make a confident diagnosis? If the answer is yes, then you make that working diagnosis and you start treating based on that. But if the answer is no, you don't have good number of clues, then you start thinking about doing a biopsy. You can go down the path of, so for lymphocyte predominant diseases, we often do bronchoalveolar lavage. So which are the lymphocyte predominant diseases? Sarcoid, NSIP, hypersensitivity pneumonitis. In these conditions, bronchoscopy is quite useful. If you see a lymphocyte predominant bronchoalveolar lavage, it really helps, because then they can decide that based on the imaging pattern and this, they may say, okay, I'm seeing a poorly formed granuloma or a well-formed granuloma, and they may decide not to go any further. But if that's not the case, then they can do a surgical lung biopsy. In some institutions, they even do what is called cryobiopsy. Cryobiopsy is a bronchoscopy-based biopsy, but it tends to take a bigger chunk of tissue, has more procedure-related complications, but it's not as good as surgical lung biopsy. And then you get a decent, interpretation based on histopathology or bronchoalveolar lavage. And can you make a confident diagnosis? If the answer is yes, you do that. But if the answer is no, sometimes the histology is also non-diagnostic, or maybe the patient cannot undergo a surgical lung biopsy. In those situations, again, we sit together, all the team members sit together, which is what we do every other Friday from 3:30 to 4:30 p.m. If anybody is interested, you're welcome to join, and decide on what should be the working diagnosis. And then based on the working diagnosis, we treat the individual. And sometimes these abnormalities evolve over a period of time, and that the temporal evolution of abnormalities in itself acts as a clue for us to understand what's going on with the patient. So say, for example, if you have indeterminate for UIP, and if it's truly a UIP IPF, that may progress pretty rapidly. And the pulmonary function decline will be rapid. Evolution of lung abnormalities would also be relatively rapid. So those are the kinds of things that help us in making a confident, or at least a working diagnosis in the setting of interstitial lung diseases. With that, I'll stop, and thank you so much for being patient. And since this is already recorded, even if I've gone a little fast, you can slow down when you're listening to it, in your private space. Thank you so much. And any more questions? Is there any other sign that you know of that you want me to address before I go? Do you have another lecture at 5?
We do not.
Oh, okay.
Thank you for your time.
Excellent. And which means that we need to conclude with a wonderful joke, right?
Sounds good.
Sounds good. So what is the drug that you should never give a dinosaur? A steroid. As in asteroid.
Yeah.
Asteroid.
Oh my gosh. Amazing.
Thank you so much, everyone. Have a wonderful evening.
Thank you.
Go soak up that extra sun.
Thank
Thank you
you.
very much.
Yeah.